Unfortunately, one of our speakers has been unable to come from the States. She had a surgical operation, I believe, but Pat will maybe say more about that. But could I just remind you, I'm sure you're used to it by now, that comments, questions by Twitter are very much welcomed, and we have two guys over here, Mark and Sarah, who will monitor those and pass them through so we can bring them to Pat's attention. But I want to welcome Pat Rutherford, who's Vice President of IHI in the United States, and we're delighted to have you here. It's obviously been a traumatic week for someone living in Boston coming here, and our hearts and thoughts and prayers are with the people of Boston at this time. But Pat, you're very welcome. We look forward to your talk, and we'll take questions at the end of Pat's presentation. Thank you, Pat.
Thank you very much, Jim. Gail, Neilsen, and I have been working on this body of work at the Institute of Healthcare Improvement since about 2004, and it grew out of our work in the work we called Transforming Care at the Bedside, which was an initiative to redesign and transform care on medical and surgical units, mostly in the U.S. and Canada, but also some in Sweden and some folks here actually in England as well. Have adopted some of those practices. The productive ward is similar to that project. And so this work grew out of that work, which was improving the discharge processes. We quickly learned that just working within the hospital setting was a limited solution, if inadequate. So we quickly moved to building partnerships with communities and clinicians and folks in the community, and built an initiative that really spanned the continuum of care, and we've gotten much greater traction. And so I'm here today to share with you not all the answers, but what we're learning to date. This is a very difficult problem from those of you who are working on this. How many here are actively working on initiatives to reduce readmissions and improve care transitions? Okay, a good number of you. So hopefully we'll have time at the end for some dialogue and some of your comments and hear what you're doing that's been successful in your areas. And there are lots of resources on IHI.org that will be listed on these slides, so I won't have time to go through everything in great detail, but I've tried to pick out some of the ones that I think may be most illustrative of the work. My colleague Gail was a former fellow at IHI, and she's from Iowa Health System, and she actually dislocated her shoulder and had a little rotator cuff problem, and so she needed to get that repaired, and so she gives her regards to all who are here, and hopefully she'll be back with us next year in Paris. And I'm one of the vice presidents at the Institute for Healthcare Improvement. I lead a lot of our large innovation projects, and this being one of them. And I will be soon taking over more leadership for our patient engagement, patient and family engagement body of work as well, which is very integrally linked with care transitions and the patient's experience over time. So what are the manifestations of poor transitions? Absence of appropriate follow-up care or timely follow-up care in many cases in the States, and the right support services. Inadequate support for self-care needs and self-management support, extra burden on the patient and family caregivers for care coordination, complex medication regimens that are poorly understood, and there's obviously greater use of high-intensity services such as the emergency departments and the hospitals for patients who cannot manage their care at home, or those individuals that are in skilled nursing facilities or nursing homes that really are that the staff there don't have the supports or adequate understanding of how best to care for the needs of that individual. Those all contribute to this problem as well. There's been much written in the United States from the Medicare database, which is the big Medicare payment system in the United States, and there's much been reported from that very large database about what the magnitude of the problem was. About 5 years ago, it was not very well understood that this was a problem. If there were rooms such as this one filled with hospital executives and others, nursing leaders, and if we were to ask them, what is your readmission rate, I doubt if many hands would have gone up. There was not really a well understood problem from the perspective of the acute care setting. If you talk to patients and family members, it clearly was delineated as a problem that we could fix. I imagine if all of you right now just took a moment and thought about your own circle of loved ones, family and friends and neighbors, I predict that there's been someone in your circle that has had some incident where they've been in the hospital and there's been a less than ideal transition back into the community and coordination of their care services. It's a pretty pervasive phenomenon, not only in the U.S. We've done some work with folks in Canada and are aware of some of the work here in the UK and other parts of Europe and elsewhere. It's a pretty pervasive phenomenon. The numbers may be a little bit different, but it's a pretty pervasive phenomenon. So this study showed that the readmissions were about 1 in 5 of individuals 65 and older are readmitted to the hospital in the States. Huge amount of cost in an era where we need to drastically reduce costs in the healthcare system. Actionable for improvement. There are lots and lots of pilot studies and a few randomized control trials that have shown that actually we can demonstrate results using different resources and different processes than we currently are. What's really of great interest to those of us in the quality improvement world is great variability. In the United States, you can see here on this map, this is not just readmissions, but readmissions is a large part of this this ranking from the Commonwealth Fund. You see that there's much variation in the United States. Well, you say, gosh, well, what do you make of that? But what's good about that, there's good news in this. The variability is not good in general, but what you can go through and say, okay, what's going on in those white states that have very dramatically lower reductions or rates in rehospitalization? Now, what's interesting, even if you take it down further, if you look within any of these states, just take Texas, you can find pockets of innovation and great work at Baylor and some other places where they have reduced their readmission rates, and then you have other hospitals that haven't. So you've got variation amongst the states, and then you've got variation within the states. So there is internal capacity, even within a region, to seek out and partner and collaborate with one another to share best practices. So some of this is innovation, and some of this is just finding out what works, under what circumstances, and how can we scale that up. So I don't think we're at the era now where we have to go find out what do we need to do to fix this. I think we know. I think we just have a very hard job in executing on those changes. To add more heat to the fire in the United States, Medicare has now introduced a penalty for hospitals using readmissions as a marker for poor quality, and that they are starting to incur a 1%, 2%, and then 3% reduction in all of their CMS payments from the center from Medicare. So basically, this is basically a tax on those hospitals and a reduction of their overall payment based on this. Now, as you might imagine, the hospitals are quite upset about this, and there's much, much debate about this because the control of fixing this problem is not all within the hands and ability of just the hospital to fix by themselves. There's work that the hospital has to do, but it also entails better primary systems of primary care, better home health, better supportive services, better community services, palliative care programs, a very comprehensive system of care to meet the needs of individuals outside of acute care. So this has got much debate, but nevertheless it's in place and has catalyzed more activity than I think would have been so if this weren't in place. Another interesting research study from Vince Moore and others looking at the revolving door of individuals, residents who live in skilled nursing facilities. That's the term in the United States. That's anything from acute rehab to subacute care to nursing home care, and those individuals are also churning at a rate of about 20%. So individuals who are discharged from the hospital go back into the skilled nursing facilities, about 1 in 5 come back in within a month. So that's not a very good percentage. To complicate matters even further, there are many care coordination and care management programs developing in the U.S. and I believe in other places. Navigator models, out of primary care, some external, some through home health, some through the payers. There's a variety of models. Basically, attempts to patch on a piece to help with self-management support for individuals, particularly those with a lot of chronic illnesses. But these randomized controlled trials basically are showing that they're not having a significant impact on reducing costs and utilization. And there is a cost implied in the implementation of these. So there's lots of challenges in the research. I couldn't find much about other countries. There was this RAND study that looked, this is last year, showed that there's wide variation in the definitions of readmissions, so there's no one uniform measurement of readmissions. Assessment of readmissions could be potentially avoided, and then the identification of factors that may prevent readmissions. So not a lot of consensus in the UK at this point. The proposed 28-day readmission rate is likely to reflect a balance between hospital and community factors, absolutely the same in the US, and might influence readmissions. Their guess is between 15 and 20% are avoidable. So similar challenges from what data we do have from here, and you may have other from your countries. So what are the major challenges? Potentially, preventable rehospitalizations are prevalent, they're costly, they're burdensome for patients and families, and very frustrating for providers. Whether you work in the emergency room, on the wards, in primary care, in skilled nursing facilities, there's challenges all around. No one provider can just work harder to address the complex factors leading to early unplanned rehospitalizations. Worth repeating. No one provider or patient can work harder. This is not an issue of compliance, and this is not an issue of doctors and nurses not trying their best to do things. This is developing better processes, connections between clinical care settings, better handover communications, and better preparations of patients and their families for the next care setting or going home. I like this Chinese symbol for crisis. On the left-hand side here, we have danger. I think I have certainly articulated many of the dangers. Dangers first and foremost for patients. I think there's dangers to the economic viability of our healthcare systems. And I think there's burnout and danger for clinicians that are in this churn within the healthcare system. And I think they could be putting their professional skills to better effect if they had better systems to work in. So we'll shift from that, and let's move over to the right, and let's look at all the opportunities that I think we're starting to see have great merit. Rehospitalizations are frequent, costly, and many are avoidable. There are successful pilots, as I've mentioned. Individual successes exist where financial incentives are aligned. That's a huge challenge in the U.S., much less so in many of your countries. And we found that working on care transitions required working at two major levels. One at the front lines, working with clinicians across the continuum of care, working together to improve care transitions. And at the state or regional level, working to align incentives, work with payers, and to really catalyze activities that will help prevent and remove the barriers that the frontline staff are having in accomplishing their goals. So what we look at in any of our ICHI projects is, okay, what can we learn from the existing literature? What do we know about best practices? And then how can we take the concepts from these best practices and where there have been successes, and how can we help to make those concepts and changes scalable? Very, very important concept. We talk a lot about large-scale change here at this meeting and other meetings that ICHI and others hold. And I think one of the challenges, in my opinion, about achieving large-scale change is I think we in the improvement world have some work to do to make the changes that have been successful in pilots scalable so they are doable in other clinical conditions and under other contexts so that they can be scaled up more rapidly. Then how do we align incentives and how do we catalyze coordinated efforts to do this work? So we were lucky to have funding from the Commonwealth Fund in the states to launch this 4-year initiative to do this pilot work in 3 states, Massachusetts, Michigan, and Washington State. And we worked on 2 levels, at the front lines, working with the teams at the front lines improving care transitions, and then at the state level, helping to establish steering committees and work with payers and help to remove some of the barriers that individuals were encountering. So let's look first at the strategy of the frontline improvement work. I love this slide because I think I borrowed this from Harold Miller from the Pittsburgh Regional Health Collaborative work in Pittsburgh, Pennsylvania. And what it shows is basically 2 years in the life, perhaps, of an individual who may have some exacerbations of their illness. And you start over here on the left, and you basically have individuals being taken care of in the community, either in their home with primary care and specialty care, or in some kind of long-term care or residential care facility in green. So what we want to do there is prevent and proactively intervene when there's exacerbations there, and basically manage their conditions and help them to manage their conditions proactively. But we know patients end up in the ED and end up with some exacerbation of their problems and illnesses. What can we do in the ED to what we call treat and release? What can we do in emergency rooms to really help emergency clinicians and staff to stabilize the patient and return them back? Oftentimes we hear from ED docs, we're worried about sending them back because there's not good access. They can't get into their primary care appointment, or they can't get into specialty care, or I don't know how, or we don't have the ability to get a home health nurse to go out to the home tomorrow. So much of the challenge in the ED to home, instead of just having them be admitted when they come to the ED, is we don't have a cadre of easily accessible community resources available at the fingertips of a lot of those ED docs. That is a condition in the U.S. that may be different in your countries, but that is oftentimes the challenge that we're having. So many places are now starting to put care managers in the emergency department so that they can prevent some of those admissions that can be cared for when they have those resources in the emergency department, and they can be then hooked up with the right follow-up care and not have to be admitted to the hospital. But then, as you know, many end up in the hospital. So what is the role of the hospital? Well, in my opinion, the role of the hospital is obviously to take care of that exacerbation of their illness or clinical condition. But it's also a very ripe opportunity to now take a look at what can we do now that we understand that the patients in the hospital, by default, that is a defect, in my thinking, of the care in the community. Something's not working, and why did the patient come back here? So what can we learn, in addition to taking care of the acute clinical problems, what can we learn about the individual and their circumstances that we then can be almost investigative reporters to say, okay, what now do we need to be putting in place when they go home in the transitional care period to prevent a readmission? Understanding both the clinical and the social circumstances, because oftentimes the problems are not just clinical as why they're back in the hospital. You probably already know that. Now, I often get pushback from the hospital staff, say, well, wait a second, we got a big enough problem taking care of the clinical problems. Now you're going to add that we need to take care of all the social ills in society. And that's not what we're asking. But we are asking to do a thorough triage and then make connections with community providers, and so there can be better partnerships on the sending out back into the community. So this is just a comparison here. When I talk to my family over at holidays, oftentimes they ask me what I'm working on, and I say, well, I'm working on reducing avoidable readmissions, care transitions when patients are in the hospital, when they go home, to improve their care so they don't have to come back into the hospital. And they said, well, that's good, but why don't you prevent them going in the hospital in the first place? And frankly, they're right. That's a more admirable goal. Let's create models of care in the community that prevent avoidable admissions. Absolutely, I think, a higher standard. And I think many of the meetings you've been here and much of the work that you're doing at home on population health and expanded role of primary care and comprehensive social care combined with primary care and behavioral health integration with primary care. All of those initiatives are all toward better chronic disease management, better helping the populations manage their conditions, and prevent unnecessary use of acute care settings, the emergency room and the hospital. Absolutely. And I think we have a window of opportunity where the patient is highly activated to do things differently, and we have an opportunity to really assess things in that acute setting where the motivation might be a little different to really do things differently after an exacerbation of their illness. So I think a lot, although those other initiatives absolutely are clearly the redesign of the whole healthcare system, I do think there is something to be learned about this vulnerable window in this 30-day period of time when they're in the hospital and then the next 30 days that will not only help us to develop the whole system of care, but also help us to think about working together as a system. Determinants of preventable readmission, tremendous complexity of the variables. The recent evidence gives us pause. It doesn't point to any one clear thing. Everybody's looking at what is the silver bullet or what's the one or two things that I can do to fix this problem. It's really a myriad of things that are broken, and thus it's going to take a myriad of interventions to solve these problems. And I think the bottom there is, I think, the most important. I think we need to start moving from a provider-centric system of care to a patient-centric system of care. Very much what Maureen said in her opening plenary about seeing the care continuum and are all the pieces fitting together from the patient and family's perspective. I think not in most cases. This is a study from Hansen, Young, and other colleagues, and Mark Williams from the Annals of Internal Medicine, basically looked at all of the care transitions interventions, basically said there's no straightforward solution perceived to have extreme effectiveness. So there's no real silver or magic bullet. But there is good news, and there's tremendously good news and very many promising things that you can take a look at. I am going over this very quickly in this presentation, but we have resources that has all of the links to all of the resources and articles and research on all of these interventions. So I can connect you to that if you can't find it on the slides. So first and foremost, they're in the hospital. That's the starting point. They ended up there for some reason. And there are 4 similar initiatives in the U.S. that have great promise and are more similar than they are different. So start with whichever one you like and take that as a starting point. Project RED is from the Society for Hospital Medicine. Project RED is a randomized controlled trial from Boston Medical Center. Brian Jack in a inner city hospital in Boston showed 30% reduction of hospital for patients going home, did not include skilled nursing facilities, and had a follow-up phone call from a pharmacist. Project Boost is the program from the Society for Hospital Medicine. ICHI's work started in transforming care at the bedside, and then the STAR initiative, and then the hospital to home, H2H, American College of Cardiology, and ICHI partnered on a virtual collaborative, bringing best practices together on reducing readmissions for that cardiovascular population. So first and foremost, work on improving care transitions. Then I'm going to talk a little bit about some of what we mean by what can be done, I think, fairly easily if the will is there. Next, you need evidence-based care in all the clinical settings. So there's better models of primary care being evolved in the United States, the patient-centered medical home. There are better models of skilled nursing home care with evidence-based care. Interact, I would highly recommend, if you're not familiar with that, to take a look at that for the skilled nursing facilities. And then there are better home care models that I think are more robust in managing individuals with very chronic conditions of the home. These two studies here. Oops, sorry. The supplemental transitional care, the Coleman model and the Mary Naylor model probably have the most research behind them. These 2 interventions here. The Eric Coleman's model is a coaching model where either nurses, social workers, or lay individuals coach people in their homes. They see the patient in the hospital, come into their home, and coach the patients on how to navigate doctor's appointments and how to manage their medications. So it's a coaching model, not a doing for the patient, and shown tremendous results in patient satisfaction and tremendous results in reducing readmissions. The transitional care intervention is an advanced practice nursing model for those really that 1% or that top 3% of patients that are very, very complicated and are really at risk for readmission, many times the elderly with many chronic conditions. That's an advanced practice nursing model that oftentimes follows the patients for 3 to 6 months. And both have shown dramatic reductions and cost savings from both of those models. And then there are other, what we call supplemental care. We need better proactive care for patients with advanced illness. In the United States, there's been studies that shown that not all patients and loved ones know about the palliative care options that are available to them. Evercare models, heart failure clinics, and many others. So there are promising approaches. How to put that all together in sequence that I think is what people are finding challenges with. I like this quote from Einstein. We can't solve problems by using the same kind of thinking we used when we created them. So we need new paradigms. We need to think about how to do work together. The very first thing we ask people to do in this work is to bring together teams from across the continuum of care. Hospital staff, folks in office practices, skilled nursing homes, home health, and community services, all around the same table, thinking together about how can they solve the problems for patients and families in their community. And equally as important is to have patients and family caregivers on that team. That is the steering committee for that community. And then how are they going to go about planning and overseeing the work? The very first thing we ask them to do, that team, now that new team, from the patient's perspective, not any of the places we work, it's from the patient's perspective, is to just look at the last 5 readmissions. You don't need to look at 100, don't need to look at 500, just 5. Your last 5 patients that have come into the hospital, look at the chart and see if you can ascertain why they might have returned to the hospital, and then interview the patients, the family members, and any of the clinicians in the community that might have valuable information about that patient. What's called like a 360 review. We have an interview guide. All of this is in our how-to guide. You can start there. You can use that. You and your team will learn an immense amount about those 5 patients to get you started. And in addition to giving you information of where your opportunities are, again, hearkening back to Maureen's opening talk, this has you see the problem through the patient's eyes. Oftentimes, those of us in quality improvement, we come with run charts, we come with readmission rates, we have a problem, we need to fix this. And frankly, I'm a nurse, and that wouldn't have excited me when I was on the front lines to see all that data. Might have been interested, it might have been, a burning platform, but really, if you want to engage the hearts and minds of people who can make a difference and change these processes, it's really about getting their hearts and minds wrapped around the patient's situation. Oftentimes, the nurses and the doctors say, well, I never knew that. I taught them, I thought they understood, but I never had any follow-up because there's really not always, we don't always work as a system. There's not a feedback loop to those individuals. Absolutely critical, transformative. Working in teams across the continuum and looking at the last 5 patients will give you a tremendous start to your program in addition to the data. Here's a story. I have a video. You can look at the videotape on our website. And really then bringing that videotape back to those stories back to your entire team will help to motivate the team as to why and create a vision what you're trying to improve. Don Berwick has a quote that I love. He has many quotes that I love, but this is one particularly relevant here. The quality of patient's experience is the North Star for systems of care. The quality of the patient's experience is the North Star for the systems of care. So perhaps in one of your first meetings, create your own vision. What's the North Star aim for your system of care? Your locality, your province, your region of the country, your trust, your country, where are you starting? Is it just one locale, one regional area, one big, where are you going? What's your North Star? What would be the experience you would want for loved ones in your family? That's where you really want to start, with the heart around this problem, and then build and measure your progress over time. So some of the paradigm changes that are important. We typically in the hospital focus, and probably in many of our care settings, on the immediate clinical needs. We now need to shift to the comprehensive needs of the entire person. Patients are recipients of care, traditionally, and the focus of the care team. Every single doctor, nurse, social worker, and any other professional clearly has patients and the best care in mind. That's why they went into those professions. But we are really not partnering in many cases with patients in a way that fully engages their potential to be partners in decision making and carrying out the plans of care. This one I like, the GPS location team. That little blue dot that shows up on your iPhone says where you are when you're navigating where you are. That little blue dot says you are here. When you take a patient in primary care, you have a GPS dot, and the care team is usually defined by who's in that locality. If they're in the intensive care unit, the team is people in that intensive care unit. If they're on the med-surg unit or the wards, it's that team. The team is now being described as from the patient's perspective. People involved in the patient's care over a year. That's a more prescriptive, that's why a patient who's chronically ill would describe their team as many different individuals, not just in different clinical care settings. Length of stay in hospitals now, getting patients out is very timely and efficient, is very important to do, and we're adding to the role of the hospital staff. They now need to help define what is the ideal plan of care when they go home. Handoffs, we actually learned this from colleagues here in the UK. We in the United States used to call this handoffs all the time. Now I think we learned it from you folks that the better term is handover. It really implies that really there is more of a human connection as we hand over the communication about patients. And then clinical teaching. One of the most profound things that we've learned here is that we do a phenomenally poor job of teaching patients and families. All you have to do is go through your typical teaching, whether you be in primary care, in the hospital, in the ED, about any clinical condition, and then ask them in their own words to say how they're going to care for themselves when they go home in an open-ended way, not do you understand. And you will find that on average, they retain 20% of what you've taught them. Now, if that's important that they have that information to care for themselves when they go home, I'm surprised that the rates of readmission are as low as they are. So using health literacy principles and teach back is a phenomenally successful way to improve patient education across the entire continuum of care. So this is a little hard to see when you, if you download the slides, you'll be able to see this conceptual framework. So this is basically what we've learned over the time in START, and this is our roadmap. So if you want to improve care transitions and dramatically reduce readmissions, these are the steps that you can take. One is you have patient and family engagement throughout. That will catalyze your efforts, and you will move faster if you engage them early and soon. Cross-continuum team collaboration, essential, cannot be done without it. And then as much health information exchange and shared care plans as you have and can develop, they are fundamental building blocks and fundamental design elements. First, start with improving the transition out of the hospital. Equally important, when you have a handover, in the Olympic relay teams, you have a handoff and you have a reception. Well, if the receiver doesn't do their steps, you can drop the baton, and the same is true in any of our care transitions. So there are steps outlined there for all of the receiving sites of care too. There are things office practices, skilled nursing facilities, home health need to do in addition to what the hospital has to do. Then all the other community-based care supports need to be kicked in and appropriately attributed to based on their needs. This is a little simpler of just the care transitions part. So this is just taking the first two sections here about just looking at the care transitions. They go home from the hospital either to skilled nursing facilities or home with different supports. But also, many patients now are being discharged from skilled nursing facilities and rehab. They have to do the same changes over there as they're doing in the hospitals in order to have a smooth transition from the skilled nursing facilities back to the community. This is the how-to guide I've referred to. It is about 150 pages filled with tools, tips, case studies, and very practical approaches for doing this work. I think many have found this very useful. We're in the process of revising. We revise it every year. The version that's out there right now is quite good, but we'll have a new version out there in June. So here's where I'd like to go into a little bit further depth with a couple changes just to give you a sense of the qualitative difference of what we're asking frontline teams to do. When I've talked to clinicians and staff in hospitals and these cross-continuum teams, we had shorthand for the 4 changes, those 4 boxes up there that I described to you, that what we wanted clinicians and staff in hospitals to do differently. And we said, we want you to do an enhanced assessment of their homegoing needs. We want you to teach and facilitate learning. We want you to develop a plan of care after they're discharged from the hospital. And we want you to send follow-up communications to the community providers and to give information to patients and families. Who here in the room here is not already doing that? Anybody? You're all doing that, right? You all have processes for assessment. Do you teach? Yeah, okay, so maybe you could do better. But in the United States, most people, when I've said that, and the colleagues that I work with, Gail and others, most people say, well, we're kind of already doing that. Until we got down into the qualitative difference, and I'm going to give you some examples about what we mean about a qualitative difference. So the first is, how can I gain a deeper understanding of the comprehensive post-discharge needs of the patient through an ongoing dialogue with patient, family, caregivers, and community providers? Now, typically what happens in the U.S., oftentimes it's nurses that do this initial assessment. They have a form. Sometimes it's electronic, sometimes it's paper, and they click through it and they do it on admission. And then it's set aside. Sometimes they refer to that in multidisciplinary rounds as they're planning with the care managers for discharge. So that's the assessment. Checkbox. We're saying something different here. We're saying ongoing dialogue throughout the whole admission. Imagine how stressed that patient and family is upon admission, whether it be an emergency admission or an elective admission. They're not going to remember everything. They're not going to be clear thinking. And they don't trust you. Maybe they've never met you before. The truth about what they're worried about, what brought them to the hospital, is going to evolve over time. So this is an ongoing dialogue. And what I like to say to the nurses, because I think they're in a very good position because they have lots of ongoing dialogue with the patients, is that their role is an investigative reporter. They're like a journalist. There's a mystery here. Why did this patient get readmitted? Not they've got COPD or they've got heart failure or they've got multiple things. That's all known. But why did they come back? And there are two questions here at the bottom that I think every nurse and every person at the bedside could ask and get tremendous amount of information without filling out any additional forms and without having to have some prompt. This can be in their heads. Why do you think you needed to come to the hospital? Ask not only the patient, but any other family caregivers that may be involved in their care at home. Phenomenal wealth of information, because that is unlikely to be on any of your problem list, and it's probably not on the things that you're planning for when they go home. The second is, what are you most worried about? Or do you have any worries when you go home? Most do. And if they do, what are you most worried about? If you can understand those two things, I think you will have the crux of what is contributing to the readmission for that individual. Not very hard, doesn't take a tremendous amount of time. I know how busy frontline clinical staff are. I think those two things can be done, and can be done reliably if we build this into the work and the mindset of bedside staff. Then additionally, the 5 whys is are you familiar with the 5 whys in the quality improvement world? Ask the why 5 times and you come to the root cause. Here's a good example. Why? A patient's not taking their meds at home. Well, why? They don't have money for their medications. Why? They don't have any insurance. That's U.S., not you folks. We still have that problem. We're working on it, but we still have that problem. Why don't they have insurance? They haven't completed their application, in this case, for Medicaid. Why haven't they done that? They need help filling out the application. They may have low literacy skills. It's a very complex piece of work there. So the patient may be labeled as non-compliant. They don't take their meds. They don't take their blood pressure meds. They don't take their psychotropic meds, whatever the situation is, and they're seen as non-compliant. But if you go deeper, there may be a different reason than what your first assumption is as to why they're not taking their medications that can be rectified. Not always, but many times. So really help the frontline staff, care managers, social workers, nurses at the bedside, investigative reporters. What do you think brought you into the hospital, and what are you worried about when you go home or the next care setting will help you be better positioned to make a better plan of care. Next, looking at processes. This is a tool for ethnography. This was developed at Kaiser Permanente, building off of looking at the 5 case studies of looking at readmissions. They've actually taken it a step further, and they actually do little video interviews with patients, and then they can use this to really show others in their team meetings about what the challenges are the patients are when they go home. Health literacy, as I mentioned, the health literacy tools in TeachBack are phenomenally beneficial, and most individuals, particularly nurses, absolutely love learning these new skills, and I think it should be built into every nursing school curriculum and medical school curriculum. This is the work of Dean Schillinger and his colleagues about the research, and it's basically a feedback loop. By asking a patient in their own words to repeat back to us, we have a better understanding of what they truly comprehend from what we supposedly taught them. Here's a very good, downloadable, user-friendly. If you want to adopt TeachBack, you don't have to go build a whole curriculum thing. This is available at this website. Gail Neilsen was the lead on this through a grant through the Picker Institute. And all the tools and resources and observation tools and all the things you need to build those competencies in your staff in any clinical setting are available to you free on the website. If you have trouble getting that, just let me know. We have how-to guides, so I've not gone through all the things, I've just given you a couple snippets. There are also how-to guides for the other care settings in the community, for receiving the patients back there, and there are tools and resources available there as well. Evidence-based care models, here's a few of them, and supplemental care for high-risk patients. You've probably heard a lot about that in some other triple aim and other seminars that you've gone to here. So that's a lot about the what. So I think there's a lot of what and a lot of things we can do differently about care transitions, better preparation for patients and families, better communication across the settings. Now how about getting this done? This is a study done from Yale University, Betsy Bradley and her colleagues, and they looked at some of the interventions that are being recommended for the ACC, the American College of Cardiology, IHI, Hospital to Home Initiative. And of the recommended practices, the bottom line here, only 4.8 out of 10 were being implemented. So 29% of hospitals had access to medication records. Only 25% of the time was the discharge summary sent to the primary care practice. Well, what's a primary care doc or nurse practitioner going to do at 2 o'clock in the morning? They may not even know the patient was in the hospital. They don't know what the change of plan of care is, the meds. So if we don't fix this handover loop, then we are not giving the best information to the clinicians in the community so they can adequately and safely care for those individuals. Similar, we had an external evaluation from Penn State on our work in STAR, and they found that deficits in quality improvement capabilities among some organizations are really challenging moving this field forward and getting better results. So at IHI, you've probably heard this before, that we have 3 things that we think are the essential ingredients to getting results: will, ideas, and execution. There certainly is will in this room. I believe that there are better ideas that exist out there. Really, I think the key is we need a lot of work, certainly in the U.S. and probably other places, on how do you get this done? How do you get it reliably done? How do you build this into busy doctors and nurses and social workers and other care managers' busy day? How do you make this the new way that we do practice? And I think it can be done. It's just going to take a little bit more time trying to figure out what those simple, scalable changes are. And I tried to feather out a couple of them, like what we're asking the bedside nurses to do, that are really not tremendously huge new jobs that we're asking people to do. So what are we learning? In the time we have left here, I think I'm going to pause here. All these slides are on the website. You can download a talk that I've given. There's a video on our website. All the resources are there. I could go through these slides. When I get a show, do you want questions and answers, or do you want me to continue to go through these a little bit more? Continue. Anybody want me to stop? Okay, well, I'll be around to ask questions. I'll continue to go through here. So what are we learning? That the diagnostic case reviews are critical. I couldn't recommend them more highly to get the hearts and minds of staff involved. Knowing about the homegoing needs emerges over time, not in the one checklist the nurse does in the admission. Family caregivers are an immense resource and tremendous knowledge. Bring them in. Teaching should happen with them as well. Learning about TeachBack, I've already emphasized. Cross-continuum team partnerships and co-designing these processes. Instead of having the office practices receive whatever the hospital sends, we're saying that the office practice teams should say, this is the form we'd like you to put it in, and have the hospitals send it out in that format in a very simple one-page summary. Vital few pieces of information, warm handovers between skilled nursing facilities and hospitals are really showing to be tremendous. So the nurses in the skilled nursing facilities have an opportunity to ask questions of the nurses in the hospital. They get that clarified. Building trusting relationships, problem solving, really phenomenal work going on in that area. We need a much deeper understanding of how best to meet the needs of those high-risk patients, though. You've probably heard a lot about the 1%, the 3%, the 5%. Still, this body of work on care transitions needs to partner with people and what they're learning about what to do for those high-risk patients, and those two things need to be merged. So working on reducing readmissions, there's the care transitions part, but there's also the connection with those that are finding better solutions for those high-risk patients, whether they be mental health or multiple chronic conditions. So what are some of our results? This is an inner-city hospital in Detroit, Michigan, very vulnerable low socioeconomic status, able to make dramatic reductions in their heart failure readmissions. And there's the numbers of discharges and readmissions. But it didn't have a dramatic effect on the overall readmission rate in the hospital. And we're looking at that deeper, and we think that you can't just go, in their case, you just can't go disease specific. We're now moving with them to go universally. They need to apply these principles for all patients and move from pilot unit to pilot unit as opposed to disease specific. This is the heart failure readmission work. At St. Luke's at Iowa Health System. There's a complete case study you can read about the qualitative work that they've done over 4 years there. That's free and downloadable from that website. UCSF, a large academic medical center in San Francisco, has done tremendous work with case management across the continuum of care. They've had a 30% reduction in their 30-day readmissions. Even more significant is that they've had a great reduction in their 90-day readmissions. Because I'm frequently asked, well, Pat, what happens at day 31? You're doing all this work in the 30-day window. We believe that the same interventions we're putting in place here are going to help with better chronic disease management over time. So this was very exciting to us to see that it's not just a flash in the pan for 30 days and then now that everything's going to fall apart. So this is one, and more in the U.S. There's more and more discussions about should be looking at not only 30 but 60-day and 90-day readmissions as well. Case study also from UCSF you can learn about in great depth about what they've been doing there. We had some parallel work going on in Ohio. They were not part of our grant, but they wanted to do what we were doing in Michigan, Washington, and Massachusetts. And the 18 hospitals that worked with us following what I've just described to you had I believe it was 6% greater drop in their readmission rates as compared to all the other hospitals in Ohio. So we're getting more and more belief in the changes here, if they can be bundled together, can have a dramatic impact. The state-based work, there's an article that was published in 2011 about our state-level strategy that I think you might find interesting. We work at the hospital level, the community level, and then at the state level, and all three levels working together, I think, can catalyze tremendous synergies. Coordinating, aligning complementary initiatives, looking at best statewide data. Getting consensus on what the data is very tough, but you really need that consistent data to really understand what the impact of your changes are. Removing barriers, co-payments, different categorization for homebound requirements, and then engaging payers. We've had some very important local successes where in some cases individuals had to have a co-pay for a home visit or early visit to primary care, and the patients didn't want to pay that. They felt like I was just in the hospital, why do I have to pay again? And the copay was small, but for someone on a very low income, that was pretty significant. So the payer said, let's waive that. It's more important to get them into early follow-up within primary care. And so there have been a lot of those small collaborative efforts where the payers have actually been at the same table as the clinicians working on these problems. The Affordable Care Act, we have many carrots per se and many things that are helping to catalyze activity in this area. And then the stick that I mentioned before, which is the payment reduction for those hospitals that have worse than average readmission rates over time. Okay, I think that's a quick overview. So I'd be interested in hearing from colleagues what's been tweeted, and if there's any questions or any comments from others, I really would love to hear what you're doing and if this resonates with you and other thoughts.
Pat, thank you very much for certainly the most comprehensive presentation I've seen the last couple of days. Excellent. So we have time for any questions. Perhaps Mark and Sarah could just update us on any comments coming through tweets.
The main theme on Twitter was the support for communication with the patients in terms of the 5 whys and specifically asking about their home situation, not just their hospital situation while they're under our care.
Could I make a comment, Pat?
Sure.
Because we had a quality improvement project in Northern Ireland a couple of years ago, and they made tremendous advances in terms of managed discharge. But their rule was they began the discharge planning on the day of admission.
Absolutely.
Because, in fact, one of the problems was they had lots of good intentions but not enough time, because the people, when we started thinking about discharge days before discharge, they start the discharge on the first day of admission.
Yes, and that's oftentimes where the nurses do the checklist, but what we're suggesting is that's not enough, this ongoing dialogue, and in many of the cases what we're encouraging is nurses to have the change of shift report happen at the bedside. So if nurses who are off-going and oncoming have that exchange of information, a lot of rich dialogue can happen about the plan of care and what's going on and what do you worry about when you go home. So really, yes, on admission, but really not just an admission, have it being part of the ongoing dialogue. I think there'll be a rich dialogue and there'll be a lot more learning about what the complexities are for patients.
Any questions, please?
I'd be interested in what you're doing that complements this as well.
Could you introduce yourself, please, when you're...
Okay. Diana Rodríguez Hurtado, Open School, Universidad Peruana Cayetano Heredia, Lima, Peru, South America. What is the age that you, when you begin to do screening to the person in order to detect MCI, mild cognitive impairment? Because it will be the cause that the patient doesn't obey the treatment and maybe readmission. It's my question. Thank you. What is the age when you decide to do?
What is the age?
The age, yes.
Okay.
Because not necessarily 60 years, maybe before. I don't know.
Very, very important question. The impetus for a lot of the work in the United States is based on Medicare, which is 65 and older. But I do not know of any hospital or any community that's only working on the elderly. They're starting to do this for all patients. Because when you look at the Medicaid population under 65, those with a lot of chronic conditions and mental health problems, equally as problematic. So I don't think, and actually I'm a pediatric nurse by background, and I actually think all of the concepts and all the things we're promoting in this approach equally as relevant for a 2-year-old with chronic conditions as it is a 30-year-old with some disabilities, as somebody with mental health problems. So I don't think it's age specific. The risk factors may be different depending on their constellation of problems. But I think what we're promoting here is not just for elders. Is that helpful?
Thank you. A speaker back here, yes?
Thanks. It's Adrian Hopper from London. Just sort of leading on from that, I mean, in our work in readmission, I mean, the very high-risk group are, rather than old people, are frail old persons, and in particular, it's the mixture of dementia, recovering delirium, and high falls risk. Now, obviously, in the UK, it's partly to do with those patients we probably send home earlier than in some other systems, so the problems will be partly system-based, but it's a particular, if you like, risk spiral to the combination of dementia, delirium with falls risk, which is one of the high-risk groups we see. And shall we say, we're struggling with managing things. Some great ideas you presented there, but I note you didn't really focus on that as a problem, which I would say is probably one of our key challenges in the UK health system.
Well, I would agree with you wholeheartedly, and that's why I made the emphasis that care transitions is part of the solution, but we need better models of care in the community, whether it be primary care, skilled nursing, and I would include within the home. So there are many, programs now, home health models and home care models are going in and fall-proofing and doing kinds of interventions in the home and helping with getting individuals in Tai Chi and other kinds of community-based resources. So totally agree. Readmissions is not just a care transitions. Care transitions is one part of the solution, but it's better models of care and helping people to manage, whether they be in skilled facilities or within their homes. And I think in this situation, I think family caregivers are a key piece. And if they're given the supports, and really, I think they're a big part of some of these solutions, and then perhaps community care workers. But absolutely agree with you. It's not just about care transitions. Equally, it's about helping people age in place and to support them with whatever clinical conditions they have.
There's one last question over here, please. Yeah.
That was absolutely excellent. The director of a hospitalist program not too far from from Hartford, Connecticut.
Okay.
And we've tried a lot of these things, and we seem to have good months, and then it all comes crashing down. And our numbers in CHF improves, and then COPD seems to slip out of the window. And could you comment on a good way to, in the inpatient setting, on risk stratifying patients? And is there a tool out there? I know there's LACE and there's LACE modified. And how do you slice this group? And is there any utility in doing this, or should it be something that you do across the hospital rather than spend time in
Boy, oh boy, that is one of the toughest things. I think that unlike segmenting by the high-risk population of the 1% and the 3% by high-risk, high-cost patients, which I think is very deserving of a lot of attention, there are so many factors that contribute to a readmission, and you will find that when you do these interviews of patients. It could be because my aunt's caregiver, who is her husband, fell ill himself. And that's why the patient's care fell apart at home, because the spouse is the one who cares for the medications. It is a myriad of complex situations. So yes, many are using administrative data to come up with some idea about what the risk stratification is and who deserves these high-risk interventions that we can't afford for everyone. In the absence of anything that is extremely reliable, here's what we recommend. That if a patient has been in the hospital 2 or more times, and the patient and or family caregiver cannot teach back what their care is and how to care for themselves at home with reasonable comprehension, they're high risk. And the first thing is they get an intervention when they go home, either from a home health nurse or a physician's office visit. And then they will decide what additional supports need to be put in place. So in quality improvement, we always talk about using evidence-based practices, but in the absence of clear evidence, we still have to do something. And so we try to learn our way into the right answer. And I think each community, each setting may come up with their own risk stratification that is a practical sense. And I am still a believer in nursing, physician, social work, professional judgment. I think if you get the right information around that table about what brought the patient in from the patient's perspective, perhaps their primary care provider and their family caregiver, if we understand what they think brought them into the hospital, what they're worried about when they go home, I think the doctors and nurses and people around the table, that clinical judgment is as good or better in many cases about what do we need to put in place when they go home as any risk stratification tool. So I think that sometimes we need to go back to basics and rely on professional judgment. And in the absence of clear evidence, I'd start there.
I'm just, all of a sudden hands are going up, so you've started something. This lady back here, about the 5th row.
Hi, I'm from New York. Hi, how are you?
I'm good. How are you?
And one of the things we did is a city hospital, Kings County, and one of the things we did was created an interdisciplinary team, a CHF task force.
Yes.
And it's interesting what we find. A lot of the information that you spoke about is in our processes. But some of the interesting things that we found, one, the patients, the negativity surrounding patients that are labeled non-compliant. And usually it's never with a why. It's non-compliant. And you have that in your medical records 3 times, and then nobody wants to talk to you anymore. And most of those reasons for not taking the medication is because of side effects.
Right.
Most of our patients at CHF are on 9 medications, 50% of ambulation issues, and just that alone, before you even get to the disease, has to be addressed.
Right.
Number 2, we found that 50% of our patients did not have a pill box with 9 meds. And the only way we found that out was to have patients at our meetings. And every morning we meet Monday through Friday, 9 to 5. I'm sorry, 9 to 10. And if we had a problem, we must ask for a question. Who's the individual? Not the patient, because our sense is that the patient label does not reflect the complexity of the individual. And so we ask, what are the fear factors? What's important to that person? And where's the person in the acceptance of the disease? And if we can't answer that, the care managers have to go back and talk to the patients and come back. And that process, we have learned so much, and we have decreased our readmission rate compared to the rest of the hospital in this particular pilot.
I couldn't agree more, and I think we need to listen to the reasons why patients aren't taking their medications, because there may be some really legitimate reasons. And there may be some simple adaptations or changes of meds or things that can be worked around. I was talking to a patient in one of the Detroit hospitals we were working in. I was just waiting in a waiting room with him and was just asking him how things were going. And he said that he doesn't take, I forget which medication, a blood pressure medication because it made him sleepy. Maybe it was a different medication. I can't remember. But some med he was supposed to be taking, he didn't take it. And then after the nurse talked to him after several times, she says, well, you know, we can have you take that at night instead of in the morning. So there are some really simple little things if we really understood the reason why. And frankly, in all of our work, we basically say you should delete the word non-compliant from your vocabulary. There is no such thing. There are real reasons behind the burdens people are living with, a lot of chronic conditions, and behind what they're doing. And we need to be person-centered and really, really understand their experiences. And I think your points are well taken. I think we're at time. I'm happy to stay longer to talk to you and answer any of your questions, but I don't want to hold you up and make you feel like you need to stay and move on to your next
Thank you, Pat. Yes, I'm sure Pat will take the round of applause, please. Thank you.